We are broadcasting live from Children's Hospital of Wisconsin. My name is Corey, and I work on the social media team. And today I'm joined by Dr. Amy Wagner and Dr. Meredith Cruz from our Fetal Concern Center. Now, Dr. Wagner is a fetal surgeon, and Dr. Cruz is a maternal fetal medicine specialist. And today we are going to be talking about what expecting parents should know after receiving a fetal diagnosis of a birth defect or other medical condition, and what treatment options are available for the baby before birth. And we would love to hear from you. So if you have questions for Dr. Wagner or for Dr. Cruz, please go ahead and post them in the comment section of this video, and we will do our best to answer as many questions as we can throughout our live broadcast. And of course, please click the like button or click the share button as you're watching this, because we would love to hear your feedback. So with that, I thought maybe a good place to begin our conversation is just to have a better understanding of what we mean by fetal care. So what do we mean when we say caring for a fetus before birth?
Thanks, Corey. A fetus that has any abnormal diagnosis can be helped in a multitude of ways from our center. The first is to give a comprehensive overview to the family about what to expect after the baby's born, and that may require an operation by myself or a lot of ongoing care throughout the pregnancy by Dr. Cruz or one of her colleagues. But it helps set the tone for the remainder of the pregnancy, answer questions for the family that they're curious about, and overall, our goal is to really relieve any anxiety that's out there to help the families feel at ease with their diagnosis, to know that we're providing the best care possible for their unborn child.
And how early in a pregnancy might an expecting mom seek out fetal care?
Go ahead.
So usually a mom will have their first ultrasound where we can sense or have a sense of what type of abnormality is happening as early as 12 weeks. Mm-hmm. And usually when the fetal care issue is or occurs, it's around the first trimester. But most of the time it's during the anatomy scan where an anomaly may occur. And
so are there, in your line of work, are there certain conditions that are more frequent than others that ultimately drive patients into our fetal concern center?
The most common condition that we see are soft markers on an anatomy scan for aneuploidy or chromosomal issues like Down syndrome.
So what do you mean by soft marker? I don't know what that means.
So a soft marker doesn't necessarily mean there's something wrong with the pregnancy or the fetus, but it sometimes needs further evaluation after birth. For example, a very common one, and there was one that got posted as a question, was a woman had the diagnosis of pylectasis, or a slight dilation of a kidney. That could be a subtle sign for Down syndrome, but if a woman has had the appropriate genetic screening test that shows a low risk for Down syndrome, then the Down syndrome concern should be off the table. But we also want to make sure that after a baby's born, that the kidney dilation resolves, and so that mom will be paired up with a fetal concerns nurse so that she is set up with the appropriate pediatric subspecialty evaluation. And in this situation, it would be a pediatric urologist.
And so how is that diagnosis made? Who makes that diagnosis?
So it's made on ultrasound by a maternal fetal medicine specialist.
Someone like yourself, then?
Correct.
Okay. Now, what types of treatment plans, then, can you put in place at the moment you receive the diagnosis? And I'm sure it depends on the diagnosis you receive as well, right?
Correct.
So talk to me through how that treatment plan might unfold.
So let's say for just any generic, I'm just going to talk about any anomaly in general. First, we inform the mom of what we see on ultrasound, and if there's any additional genetic testing that can be offered, we talk to them about that at the same visit. And then we will call the Fetal Concerns program and let one of the nurses know that we have a new intake, and that nurse will then come in and introduce themselves to the patient and basically be there for the patient for any other follow-ups that may be needed. For example, if a heart defect is discovered on ultrasound, then the fetal concerns nurse will then set that patient up for a special ultrasound to look at the baby's heart, and then meet with a pediatric cardiologist to talk about what the diagnosis is and the prognosis.
Now, for women who are at risk for a high-risk pregnancy, what types of concerns should a woman have if she's maybe at risk for a high-risk pregnancy, and do those tend to be more of the patients we see, or?
So most of the patients through the Fetal Concerns program would be high-risk pregnancy because there's a concern with the fetus. Mm-hmm. There's a lot of high-risk pregnancies that just involve mom's health and that generally is taken care of by a maternal fetal medicine specialist. And a mom can have a comorbidity like hypertension or diabetes that may not necessarily cause a defect in the pregnancy, and so that woman may not necessarily be referred to the fetal concerns program.
Now, what about pregnancies that involve twins or multiples? Are they tend to be more high risk, or are there complications involved with that?
Twins and higher order multiples like triplets, quadruplets, yes, they are at risk for other complications. The main complication is preterm labor and preterm delivery. Sometimes anomalies in general, anomalies are a little bit higher in that patient population, and if that happens, then they are referred to the fetal concerns program. But a lot of the surveillance is done by maternal fetal medicine specialists, and then if a concern arises, then they get referred to the fetal concerns program.
And so, Dr. Wagner, as this care plan is being put together, sometimes we could actually do surgery on a fetus before the baby's born. Is that right?
That's correct.
What types of conditions typically, or could you do fetal intervention surgery on?
The most common operation that we do here is a problem with twins, where twins share one placenta and the blood supply between the twins is not equal, and one twin gets too little blood supply and the other twin gets too much blood supply. And unfortunately, they can both pass away because of that problem. So we can go in with a laser and disconnect the blood supply that is joining the two twins so that they each have their own share of the placenta to help prevent them from having all the problems with blood flow and heart problems that can occur after that.
Now, for somebody like me, I'm trying to wrap my head around just even the possibility of doing surgery on a baby before the child is born. Can you set the stage for me? Help me understand how that works,
Yeah,
right?
it's crazy, right?
Yeah. How does that work exactly?
I'll explain the other operation that we do commonly here,
Okay.
and that's open fetal surgery that we commonly do for spina bifida,
Okay.
because it's even more, I think, astounding to think about actually making an incision on the mom and opening the mom's uterus and exposing part of the fetus. So the mom is asleep during the operation. She gets a general anesthetic, so she's not awake at all, unlike a cesarean section or other types of interventions for the fetus, but she's asleep. And so we make an incision on her abdominal wall, and we expose the uterus. And we work very closely, myself with my MFM colleagues, to figure out where the placenta is, to avoid the placenta. We make an incision far away from the placenta, and then the next part is making sure that the volume of fluid in the uterus remains normal, because if all the fluid rushes out once we open the uterus, if the amniotic fluid rushes out, then the cord can get compressed and the uterus can start contracting, which is not what we want. We want the uterus to be a calm environment and to remain pregnant afterwards. So we put fluid in the whole time that's warm, because we have to keep it the perfect temperature for the fetus. And then we expose just the part of the fetus that we're operating on. In the case of spina bifida, then our neurosurgical colleague, Dr. Andy Foy, comes in and does the repair of the spine. And then the fetus gets put back. I close the uterus. We make sure the volume of fluid's enough. Throw a little antibiotics in there for good measure to help prevent an infection. Close up mom, wake mom up, and then she stays with us in the hospital typically for about 4 or 5 days, recovering.
But you make it sound so easy, right? But the idea is then that we want mom to stay pregnant.
Correct.
As
That's
long
where my
as
maternal fetal medicine
she
colleagues
can,
come in.
right?
Yes.
Now, who is all in the room? Because it's not just you, right? You mentioned Dr. Foy.
Correct.
Who else is in the room?
It's a large group of experts that are, everybody is on the same page at the same minute providing outstanding care for the mom. So the mom has her own anesthesiologist. The fetus has his or her own anesthesiologist. There's either Dr. Cruz or Dr. Peterson, or both sometimes. They're making sure that the placenta stays healthy, that the amount of fluid is healthy, and moves the fetus to where we need the fetus to be before we make the incision. Myself and I usually have an assistant helping me as well, Dr. Foy. And then we have a pediatric cardiologist scrubbed around the table as well that is watching every single heartbeat of the fetus to make sure that the fetus stays healthy during the entire time. Because most operations we do on more available patients that we can check vital signs and check oxygen levels and check labs and a heart rate and blood pressure. We can't do all that on a fetus, so we use the echocardiography by the cardiologist to watch every heartbeat to make sure that the function of the heart looks normal. And if the function changes, then we know the fetus is becoming distressed.
So the level and depth of expertise that you just described in that scenario astounds me. It does. Is it unique that Children's Hospital of Wisconsin can offer that type of procedure?
It's incredibly unique, and we're really one of the only handful of places in the country that's able to provide this for our patients. I didn't even mention the people in the room, like the operating room personnel that are also experts in this, the nurses, the sonographers. The entire team is just an outstanding group of individuals dedicated to providing excellent care for these patients.
So if you're a mom and you've received a diagnosis that you could receive some sort of fetal intervention surgery for, is that a choice that mom is making, and how does she weigh that decision?
It's a great question. It's a difficult choice, and I do not envy any of these moms trying to decide what's best for their family. The mom herself has to be entirely healthy. She can't have any other health problem. She can't have had certain previous operations on her uterus, particularly fetal surgery or something called a classical C-section, because then there's the risk of the uterus not healing well. And then the fetus can't have any other abnormalities. Not only for spina bifida, there can't be anything else that's not usually associated with spina bifida that could impact the health and the recovery of the fetus. The mom can't have had previous preterm labor. There's a long host of things that both the mom and the fetus have to meet to become possible candidates for surgery. But then also there's a major impact on the family, as during the recovery time, mom needs time off of work. Sometimes they have to actually relocate here temporarily to recover. So there's a substantial impact for the family that they have to consider.
And does every fetal intervention surgery mean you've corrected the problem, or is it quality of life, or does it depend?
Good question. It depends. The classic indication for fetal surgery back when this started in the early 80s was only for patients that had a life and death situation, and then fetal surgery would be offered just to save the fetus's life. Now our technical advances have improved enough that we offer it for quality of life. For the case of spina bifida, for example, it's not a life and death issue anymore. It's just trying to improve the health and overall ability of the baby then to be able to not need certain brain surgeries called VP shunts and to be able to walk in childhood.
So if you're a mom and you've received a fetal diagnosis, what's the first thing she should do?
So the first thing she should do is obtain as much information about the diagnosis as possible, and she should be given testing options based on the diagnosis, and then she should be, if not already under the risk of under the care of a maternal fetal medicine specialist, she should be followed closely by a high-risk obstetrician in addition to her regular OB, and then ideally, if there is a fetal care program like the Fetal Concern Center, should be enrolled in that type of program so that that program can provide her comprehensive care throughout the pregnancy.
And what role then does genetic testing have in either the diagnosis or the type of care that is ultimately able to be provided to a mom in this situation?
It's more information. If the fetal anomaly is a result of a chromosome issue, and if the chromosome issue is known to be not compatible with life, then that really impacts a mom's decision of what her next step is going to be after she receives the diagnosis. Sometimes the genetic testing is important for also just giving a mom a prognosis of what is going to happen after the baby's born based on the genetic test results. Sometimes it can impact a mom's chance of having this issue happen again. And so that's more information for mom.
It looks like we have some questions from our Facebook fans. So if you're watching right now, please go ahead, post your questions in the comments section of this video, and I'll try to answer them. And so what's our first question?
Amy would like to know, she says, I have a question on intercranial bleed at 30 weeks. Is there a good chance that the baby will come out healthy if they're allowed to stay in until term?
Okay, so it depends on the significance of the intracranial bleed. Unfortunately, there aren't any good tests that we can do while the pregnancy is still, while the fetus is still in the uterus, to give you the exact prognosis. And when we're dealing with something like a an issue with the brain, the best that we can offer is assessing the baby after the baby's born to tell you what exactly is going on. We don't typically, when we see a bleed, the damage has already been done if there is any damage that can occur, and so delivering a baby or a fetus once we see the bleed, right when we see it, and putting the mom at risk for prematurity does not help the situation. So getting the pregnancy as far as possible to get that baby as mature as possible to deal with whatever needs to happen after the baby's born is our ultimate goal.
Thank you.
And we have another question that came in earlier from Kay, and Kay asked, how do doctors treat kidney transplant recipients that want to conceive? So it sounds like Kay must have had a kidney transplant, and she's looking to conceive. And is she at risk for anything during her pregnancy?
So women with kidney transplants, it all depends on what medications you're on, what your kidney function is at the time of pregnancy. So the women with kidney transplant should first talk with a maternal fetal medicine specialist before even attempting to conceive to see what your risk may be. If your kidney function in general is good and you're not on any medications that could harm the pregnancy, in general you can have a healthy pregnancy with minimal risks. But the risk that any woman with a kidney transplant has is worsening of the kidney disease and having high blood pressure during pregnancy.
Okay. Looks like we have another question.
Megan asked, are there any prenatal surgery options for omphalocele?
Not yet, unfortunately. Maybe someday there will be. Generally speaking, for omphalocele, we can help. We would be happy to talk to Megan, or when we do have patients with omphalocele, we tell them what to expect based on the size of the omphalocele, something that we can predict by certain measures that we take on ultrasound. If the omphalocele is small, the good news is usually those patients are able to have their omphalocele defect closed shortly after delivery. If the omphalocele is large, then we have different ways of temporizing it and then having definitive surgery later in life. But really for omphalocele, the main outcome of the child is based on other abnormalities. So I'm not sure if Megan's child has other diagnoses in association with it, because omphalocele can be associated with chromosomal abnormalities or cardiac abnormalities. But nothing at this point we can do prenatally, not yet.
Thank you. And with any type of anomaly, you have to weigh the risks and benefits of preterm labor and delivery with a fetal intervention, and probably with an omphalocele, those can routinely get corrected after birth by a pediatric surgeon without any complications, and so taking on the risk of correcting it during pregnancy would probably not be worth it because of the risk of preterm delivery.
Mm-hmm.
Great. We have one more question from Karina. She said her previous pregnancy had an undetected IUGR and she went to 39 weeks. She has a history of miscarriage, one due to Turner's. She's now 11 weeks pregnant with number 2, and she's very nervous of chromosomal disorders and IUGR. What advice do you have?
So for this pregnancy, I would recommend that you do see a genetic counselor and learn about all the screening or genetic screening tests that are available to you. There's now a blood test that you can get that's non-invasive. It's basically detects fetal cells that are circulating in your bloodstream that basically come off the placenta, and it can give you as high as 99% accuracy of whether the pregnancy is at risk for Down syndrome or not. You could also it also looks for other conditions like your risk for trisomy 13 and 18, and then also you always have the option to get 100% answer by undergoing a procedure like a chorionic villus sampling or amniocentesis, where we just sample the pregnancy and look at the cells and see if the chromosomes are normal or not. Thank you.
Thanks. And again, if you're watching right now, we really appreciate it if you click the like button, click the share button, and let us know you're watching. One question I have is, what opportunities exist when caring for a fetus that might have a heart condition? Is that something that's possible?
There's some prenatal intervention for cardiac diseases, very specific cardiac diseases, that are done in a few centers in the country right now. It's the overall long-term research on fetal cardiac intervention has not completely been solidified yet, but it's something that we are looking into here to consider in the future offering our patients.
Okay. We've talked a lot about the role that each of you have in our Fetal Concern Center. What about the role of someone like a nurse care coordinator? What role do they have in interacting with the patient families as they go through this experience?
So I believe the nurse coordinator plays a very vital role in a patient's experience. She's going to be the one constant that the patient has through the whole experience and guiding them to the appropriate people to meet, and is basically available whenever the patient needs that nurse, if she has any questions or concerns, or just to even provide thoughts of what the patient may be going through. They're always available by phone or email, and the nurse essentially becomes the patient's best friend through the whole experience.
And I'm also curious then, what role would you say a NICU has in the overall care that can be provided to a baby that might be diagnosed before delivery and then ultimately need care after delivery? What role does, like, for example, our NICU have in the work you guys are able to do?
The NICU is a very important part of obviously the entire hospital. The benefit of our center is that the delivery room for the mom and the NICU soon will be right down the hallway from one another. So that's pretty unique actually around the whole country. Currently the NICU is down a few floors, but it's still within the same hospital, so the mom and the baby never need to be separated, which provides an enormous amount of benefit not only for the care of the mom but obviously for the entire family. The other great thing that our Fetal Concern Center can offer is the mom can have tours in the NICU before the baby's born, and just to get a sense of what it will be like when the baby arrives and what a family will be expecting to see after their child is in the NICU if their baby requires those services.
I'm curious, in both of your professions, when you look ahead in the future, what are you looking forward to? Are there innovations on the horizon? Are there treatment plans that you're hopeful for some of the patient families that you see?
Well, I'm looking forward to finding the cure, not myself, but somebody out there will find the cure to preterm labor. So it won't be me, but somebody in the universe will figure out why women go into labor to begin with and why they have preterm labor and how we can stop that. Because preterm labor is really the Achilles heel to any fetal intervention. We know that they're at very high risk. In some cases, we are certain they will have preterm labor. It's only a matter of when. And that obviously has many negative impacts on the baby's overall health. So someday I'm looking forward to seeing the end of that.
Yeah, I agree with that.
Okay. If parents out there are unsure how to select a hospital with a NICU or unsure where to seek treatment, what advice would you generally give them when they're online doing their research, trying to find the right place to receive care for their unborn child?
So I would recommend that a patient finds a place that would provide them comprehensive care under the same roof with all the subspecialists that they may need, and that the NICU is within the same vicinity as the labor and delivery, so mom and baby will never get separated.
And then is it important, you think, to seek a second opinion? I mean, would you recommend somebody seek a second opinion if they're unsure about their original diagnosis or the plan that's put in front of them?
Absolutely. I encourage all my patients to do that regardless. I mean, I think having confidence in your healthcare team and ease of mind is so beneficial for every single person. So there's no reason, I think, ever to not get a second opinion if you have any outstanding questions or just want to hear another perspective on things. Absolutely.
I think a great benefit that our patients have that come through our program is that we provide comprehensive care, so they're hearing the same message from multiple providers. So I feel like most of our patients don't seek a second opinion because they become confident with the information they are given from us.
And what do you think are some of the things that make the Fetal Concern Center here unique? We talked about having a NICU on the same floor as the birth center at Freighter, right? What are some of the other things that you think that make our program unique?
I think, well, Children's Hospital Wisconsin is one of the best hospitals in North America and is the reason that I practice here today. So the outstanding level of care from not only my colleagues, but the entire hospital is one I'm so proud of and really, truly one of the best in the country. It's one of the only level 1 surgical care facilities in the entire country at this point, meaning that babies and children that require an operation have the best anesthesia, perioperative, and surgical management here compared to other places in the country. The benefits go on and on, Corey. It's hard for me to answer that question in a minute, and I know we have more questions.
So it looks like we do have maybe another question or so from our Facebook fans.
Lauren said, I had to have an emergency C-section at 31 weeks because of no amniotic fluid and bright kidneys. He was transferred to Children's NICU and was clinically diagnosed with HLH. He lost his battle after 2 weeks of life. Would this be a good program for my next pregnancy?
So this program would definitely be beneficial to you if your next pregnancy is complicated by any concerns, but there is a good chance that your next pregnancy will be normal. You definitely need to see or meet with a maternal fetal medicine specialist and have your 20-week anatomy scan with a maternal fetal medicine specialist and a consult to assess what your risks are. But the chances of you experiencing something again are low, but if it does happen to happen, this would be a very great program for a situation like that.
And we have one question from Erin. She would like to know if there's any new research on preeclampsia and if it's likely or unlikely to occur in a second pregnancy if it occurred in the first.
So preeclampsia is still the one major problem that many people are trying to do research on. We still don't have a cure for preeclampsia. We have some ways to try to prevent them in future pregnancies. And one that has preeclampsia in the past is definitely at risk of having it again. It's important that a woman knows what her blood pressure is when she's not pregnant, because if she has some underlying mild blood pressure, that might be important to know before she attempts to conceive again, and she should be followed closely by a maternal fetal medicine specialist in addition to her regular obstetrician.
So kind of as we wrap up our conversation today, I want to ask you each one more question. So Dr. Cruz, what do you love most about your job?
So what I love the most is the variety of care that I get to provide for my patients. I love seeing my bread and butter medical complications with women, and then also taking care of pregnancies that are affected as far as fetal anomalies. I myself, along with a couple other partners in my practice, do provide other procedures that are unique to our specialty. Like we can sample the placenta. Not all maternal fetal medicine specialists can sample the placenta. We can transfuse a fetus if they become anemic. We can also perform other procedures, like if there's a bladder outlet obstruction, we can shunt the bladder and things like that. So the variety that I get to do in my job is what I love about it most, and I love working with the colleagues in the Fetal Concerns program.
Dr. Wagner?
Mine is the long-term relationship that I develop with families. I'm so fortunate in that a lot of my patients I actually meet before they're even here. I meet them as fetuses, and I meet with the parents first. And then I operate on the baby after the baby's born. And then I follow the patient up until, for decades, really. I joke with the families all the time that once your child goes to prom, you won't need me anymore. So it's so rewarding to have this long-term relationship with families over years and years and watch their child, become better and be a part of that. It's really gratifying.
So if there is a family or a mom out there who is sitting at home watching this video and they're still unsure what to do next, if they still have questions, what recommendations or advice would you give them right now?
I would say to just give us a call. We're happy to see any patient with any question. No question is too small. If it's bothering you, you deserve an answer to that, and we are happy to help clarify anything that you're wondering about, give a second opinion. We actually have a second opinion program online that's fairly easy for patients to be able to obtain. But please give us a call. We'd be happy to see you.
And so if you want to learn more about our Fetal Concerns Center, Dr. Cruz or Dr. Wagner, you can visit our website at chw.org. And again, if you liked what you're watching today, I would really appreciate it if you could click the like button and click the share button. Thank you both so much for your time today.
Thanks,
we really
Corey.
appreciate
Thank
it.
you.
And thank you all for joining us.